Okay,
Yeah,
next
why we
disorder
can't have
that
it?
we'll
We're recording it
discuss
anyway,
is osteoarthritis.
right?
This
Whatever.
one is still an autoimmune disorder. It's still an inflammation. It's a little bit of a unique disorder in the fact that it's typically one joint, not that systemic bilateral thing that we've been talking about with other ones. This is probably a little bit more of what you're familiar with. Maybe you have people that you know of that have had joint replacements, hip replacements, knee replacements, and so forth. What's unique about this one is it's not bilateral, it's not warm, and it's not that typical presentation that you expect with an inflammation. What has happened here is that it's basically bone on bone. So the cartilage is broken down, and that's why they're having so much pain, so much mobility issues, is that you're supposed to have synovial fluid that lubricates between your bones within your joint, and all of that is absent, and now you're just rubbing bone on bone.
Ooh, that's hurt. That gotta hurt.
That's the reason they're having so much pain. There are risk factors for this one, stress and wear and tear on the joints, including additional weight, sports activities that are traumatic on the joints. I was talking to my brother-in-law, who's a physical therapist, and his concern with traveling teens, people and kids that are playing sports year-round at young ages, is risks for some of this kind of stuff. He said bodies aren't designed, for the most part, for young people just to 24 hours a day, practically some, every day, to be constantly wear and tearing on their joints with soccer, football, and things like that. So something to give thought to. Probably has some merit there. Again, pain, stiffness, all the things we've been talking about. What is crepitus? Crepitus. What does that mean? That grating sound that you can hear sometimes, you can feel it, sometimes put your hand on the joint, yep. Again, because it's not an inflammation with a synovial fluid, running blood tests, pulling off synovial fluid and testing that is not helpful. Again, my best advice when you're trying to sort out the different disorders we talked about today, stop and ask yourself, where is the inflammation? And that will help you guide you as to what you're most concerned about and what kind of test might be appropriate for your patient. Maybe x-rays, yes, to assess the joint space. So treatments, similar to what we've been discussing already, with a red caution sign for those patients that are taking things like Tylenol arthritis to manage their pain, is what's in the yellow box. Or any of us all that are taking perhaps acetaminophen on a routine basis. High risk of liver damage, especially if they're already at risk because of alcohol intake, and the dose is over 4,000 milligrams a day is what flips them into a high risk category. I would know that. If you're assessing your patient's medication profile, I see that you have osteoarthritis. Tell me what kind of medications you've been taking. Is there anything in his history or her history that's going to concern you that they're going to be at greater risk for liver damage? Thus, when you take your NCLEX, you're given a patient chart. You have 6 questions in a row that are an unfolding case study when you take your NCLEX. You're given a patient chart. You're given an initial visit, information about the initial visit, and then it unfolds as you progress through the next 5 questions. So the history is there for you to use through all 6 questions related to that particular patient, and it unfolds. Results, additional information keeps getting tacked on. So just like you do to take care of patients, look through the history and try to determine if there's anything in there that you should be factoring in your decision making. NSAIDs, we've been discussing that. As always, the concern with NSAID frequent routine use is the concern about increased bleeding. Dark tarry stools are never normal. Either is petechiae, hematomas, things like that. Use verbiage that the patient can understand when you're the nurse. You get used to using terms like hematoma. If I saw on my chart, if I wasn't a nurse, I saw SOB, how would that have come across to a patient? Wonder what that means. So we take for granted things like that we don't think too much about, honestly, but put yourself in the patient's perspective. What is dyspepsia? What does that word mean? Indigestion, dyspepsia, that word in the fourth bullet. Indigestion, yes, this always means difficult, right? And think about Pepcid, you're thinking about medications, so that might have been able to help you figure that word out. Those of you who take Pepcid or have used Pepcid for indigestion, heartburn, things like that. In red and gold and a caution sign, if you are prescribing medications like Celebrex, which falls in this category of medications, COX-2 enzyme blocker, there is an associated risk with cardiovascular disease. Again, look at the patient's history. Are you given information about his history that would warrant you discussing, thinking about, oh, this patient should not be taking this medication? Celebrex. Celebrex starts with the C. Cardiovascular starts with the C. I don't know if that's helpful for trying to put those two together. Actually, it's a black box warning on the side of the Celebrex box. There have been enough incidents, cases, where a patient with cardiovascular issues has taken Celebrex and had some serious adverse outcomes. So given a patient's history, if he has a history of some kind of cardiovascular disease of some sort, question in your brain whether the Celebrex would be a good choice for him or not, or her or not. And the answer to that is no. Again, we could do corticosteroid injections, might be helpful, because as we talked about, OA is bone on bone, getting some lubrication in there, getting some anti-inflammatory in there. It's painful when you're just rubbing joint on joint. Every 3 months is the most frequently that you can have those. Topical analgesic agents work well for a lot of these disorders. Those are like those lidocaine patches that some of you all have been putting on in clinicals. The guideline is 3 at a time maximum, 12 hours on, 12 hours off. They sell some of those in Dollar General and over the counter and prescription ones. People seem to think the generic ones work okay. We talked to a patient about that a couple weeks ago when we were in clinicals. So you wear gloves. You indicate when you put those on. Teaching is 3 hours, 12 hours on, 12 hours off, maximum 3. Help your patient guide you. Like I'll say, it says these are supposed to be on your back. I'm going to put my hand around your back until you tell me where you have the most pain, because that's where I want to put this patch. And then we can add fake viscous fluid in there, because again, we were bone on bone, right? And that's the pain. And we can inject jelly-like stuff to serve as a lubricant between that joint. And a lot of times, before a patient can get a hip replacement or anything like that, sometimes the insurance company will dictate what you can get done and what you can't. You know, they say, we're not going to approve a hip replacement until you go through so much physical therapy, so many injections like this, so much that, until you can actually warrant and justify us paying for you to get your hip replaced. So sometimes working through that with the patient, having a care manager, somebody that's knowledgeable about that, and it's just the hoops you got to jump through sometimes to get it paid for and approved. Otomy, how is that different than an ectomy? Otomy. Otomy is an incision into. So orrhaphy, O-R-R-H-A-P-H-Y, is repair of. Otomy is an incision into, and ectomy is removal of. What is an ostomy? Oscopy. Or ostomy, let's start with ostomy. O-S-T-O-M-Y, ostomy. Opening, right, like a colostomy, those, yeah. What is an oscopy? O-S-C-O-P-Y. Scope. Don't mix those up. No, your doctor did not prescribe you to have a routine or have a colonostomy. It's a colonoscopy. If you're a certain age and they want you to go through that to examine if you have any. Again, you can tell I've had conversations. Oh my gosh. we actually were trying to watch a movie last night, and there was a somewhat medical related one. My husband goes, "We're not watching that because you're just gonna correct everybody that's on there." He said, "I'm probably going because you probably will." Just can't help it. It's okay. And now you're all in the same boat because you're all knowledgeable. Arthroplasty is when we replace the joints as well. So just terminology for that. So I guess I would say for osteoarthritis, how is that different than the rest of the diseases we've talked about so far? Correct. It's not so much inflammation, it's not that worn appearance that you correlate with inflammation, you're exactly right. The problem is bone on bone. As it says in the name, osteo means bone. And still same issues, still same problems. Sometimes Celebrex is ordered. If Celebrex is ordered for any of these, what would you caution about, or what's the risk of?
Cardiovascular disease.
Cardiovascular, so look at that, see if there's anything that's gonna be a risk factor for that. And we may supplement, put that gel-like substance in there, viscosublimation, which means you would just put that in there to try to provide some lubricant and gel-like stuff between the bones. Okay. This is just a big category of disorders that fall into this group. I'll tell you if there's something specific. Like I said, there's over 200 or something rheumatic disorders. Inflammation, autoimmune still. Finally, this one affects men more than women. How about that? Here's a breakdown of what they are. This one, ankylosing. The problem is the inflammation is in the spine. Spondylitis kind of speaks to that. And the problem is the inflammation is in the spine. So what is his posture like? Slumped, kind of hunched over. So what body system were you most worried about for him? Respiratory. You know, he's hunched over like that, and what's his ability to take a nice, full, big, deep breath? Every time. Limited. So that's your concern as his nurse. That's the body system that concerns you the most, is his ongoing ability to expand his lungs and have adequate oxygenation and respiratory status. As it progresses, more ankylosing, less ability to expand those lungs. Reactive arthritis is usually following an infection. As it says, it's a reaction to an infection, and then all of a sudden they develop arthritic symptoms. Concerning for a lot of patients because it sometimes comes on and then you're like, am I going to end up having some sort of ALS, some sort of autoimmune disorder? Which, yes, this one falls into that category, but that inflammation typically follows an infection. Or Reiter syndrome also, look at all the little sores that are developing. Psoriatic arthritis, you may have seen people with that. It's associated with the skin disease, psoriasis.
That's terrible.
Itises and lots of spots. Same treatment plans as we've been discussing. There's a biologic therapy where we can make antibodies in the lab and inject those. So stay tuned whether those will continue to be effective or not. You probably may have heard some of them, Enbrel. I mean, they advertise that particular medication that goes in that category. Okay, on to gout. Gout is men more than women. A lot of times there's a correlation between someone having a gout attack and their lifestyle activities or their dietary choices, things like that. There's an increased level of uric acid. It causes crystals to build up, deposit themselves in the periphery. It can cause kidney stones. So stone build up, crystals build up. That's the problem here. Some uric acid levels are listed as 2.5 to 8. This particular information says 6.8. If I give you a level, it'll be greater than 8. So you have a patient with gout, you expect what uric acid level, the number will be greater than 8.
You said it will never be greater than 8?
What?
It'll always be greater than 8?
If I'm trying to have you recognize that it's elevated. Because one high number in one source says 6.5, 6.8, it will be elevated. That's what corresponds to you having gout. So one high level number says 6.8, another source says 8. And those varying ranges that you all have to deal with when you're talking about lab values. If I'm trying to help you pinpoint and figure out that it's an elevated uric acid level, I will give you a number greater than 8 on your test. I won't give you a 7. It's high in one book, it's not high in the other book. It's super confusing, right? Just talking about some magical number. So what happens is metabolism gets messed up, the purine buildup, increased concentration, you've got urate crystals that form in the joints causing severe pain, swelling, redness, and then you have a gout attack. A lot of times there are things that bring on an attack. Sometimes we'll look back and they'll have had a severe dieting pattern. You know, they're on a month of starvation diet, so they only eat certain numbers of foods. Red beets are big culprits that will bring on a gout attack. A gout attack means that those crystals have formed up and they cause you to have a big inflammation situation. So people that have gout say, well, I have this flare up, I have this attack. Where sometimes you don't have too much trouble with it, and all of a sudden you have something, and all of a sudden you wake up tomorrow morning and things are inflamed and red and things like that. Typical will associate with a big toe, which is weird, I don't know. But it also obviously can form in other spots. Look at that hand over there.
Whew.
Yeah, ooh, right. Starts out typically as sort of an acute arthritic area, general, and then you'll have a lot of severe pain in one small joint, typically the great toe. More attacks, more joints. Those bumps, Sophie, that might hurt. Those are just built up of those crystals and those little make those little balls of those bumps. Sometimes we can aspirate to see those, evaluate those crystals. Imaging, diagnostic studies help none. Anti-gout agents are pretty effective. One is colchicine. The anti-gout, the problem is an increase in foods that are high in purines are problematic. This medication has ene on the end of it. Colchicine, I-N-E. So sometimes you can get that drug associated with purines, which is associated with gout. Gout has a U in it. I don't know. Just have to do cheesy stuff for these, some of these meds. Allopurinol is another one. That's a great name. Purine, allopurinol is another one that we like to use. Again, liver and kidney function tests. As we know, some of those are pretty toxic on those organs. It's okay for you to take these, and we have them prescribed for you, but we do need you to monitor your lab tests to make sure they're not going to be stressing your body organs out too much. And we also have other medications that will dissolve the urate that's been deposited. Patient teaching is huge for this. If you want to keep this inflammation under control, and if you don't want to have these gout attacks, which means you're going to wake up tomorrow morning and have a big inflamed, red, hot, miserable, sore toe, probably need to monitor what you're eating, because there are some definite associations. Like I said, diets will cause it, diuretics cause them sometimes to have an attack. As with kidney stones, as with this kind of crystal buildup, more and more fluids. Stay hydrated. Drink lots of fluids. Because the thyroid just keeps moving that stuff through there. Alcohol will cause a person to have, a gout attack. Organ meats, oily fish, sardines, tuna, high purine foods, all of those things should be avoided if you want to try to avoid a gout attack. So patient teaching is huge for this one. We want to keep you not having those again.
So for the meds, like,
You're okay. Colchicine?
Yeah, with that, do they take it regularly or do they take
Yes.
it when they're having a gout?
No, typically regularly. We want to avoid you from that crystal buildup and having an attack. Yeah, good questions. That is great clarification. And also for your patients too. I'm supposed to take that when I'm having a problem. I'm supposed to take it all the time, on the clock. Make sure those instructions are clear. That's a great question. And sometimes people will know that. I just know that because my brother-in-law was at Oktoberfest this weekend. And he said, but tomorrow morning when I wake up, my big toe's gonna be really, really sore. I don't care. As he drinks out of beer, I'm like, oh! Knowledge doesn't equate to compliance. So, but your job as this nurse is to increase the teaching there. Questions about gout. Elevated uric acid level, know your medications, know your patient teaching that will go with that. Or this is the patient's history, looking at that, what do you think probably brought on the gout attack? Something like that. Fibromyalgia, this falls in this category of diseases as well. It's kind of, again, a little bit different. It's a chronic pain syndrome, as it says. Algia means pain, myo means muscle, so muscle pain. The problem is it's a dysfunction in the signaling from the brain down to the joints. So fibromyalgia is increased pain. Their pain receptors don't get the same message as yours do. That's the problem. So your pain receptors, your brain says you could probably sit for another hour after lunch. It's probably okay. You're not probably in significant pain. They're messaging their pathways to say something much different. So sometimes this disease doesn't get a fair shake because people think that they're just their wimps. Oh, for gosh sakes, you could surely sit for that long, right? Well, no, their pain receptors are telling them something much different than yours because of the brain messaging that goes on. So this is actual disease, a disorder. It's really hard to diagnose, as you can imagine, because, oh my gosh, I'm just so miserable. I only sat for 20 minutes and I just can hardly stand it. Well, let's try to see if there's something in your spine. Is it a bone? Is it a joint? So it takes a while for us to figure that out. It's not a mental health disorder, and it's not like they're just wimps. It just is actually a missed message from the brain to your pain receptors. They have pain when you may not. Again, we have a little criteria sheet we try to go off of as to when you're having pain, where you're having pain, try to figure out what you've got going on so we can diagnose you correctly. All the things that go with that, sensitivity to certain products, stiffness, joint pain, numbness, tingling, because all the nerve pathways are not sending the right messages. NSAIDs, we can do antidepressants for these patients, and it's not to make you feel less depressed about this diagnosis. We're trying to improve your messaging from here down to your pain receptor. That's the purpose of that.
How would a patient describe himself being from the other ones?
Like you're saying, I can sit there, I can ride into work, and in 15 minutes, I'm just miserably, it's just got pain everywhere. I've only ridden in the car for 15 minutes.
So do we need to see pain assessment to?
Yes. And like I said, it's hard to diagnose because you saying that I feel miserably pain after 15 minutes of time, I'd be like, well, I don't even know what that means for sure, right? And that's why it's hard to figure that out, because we gotta figure out that it's just a mismessaging. It's not like you have fractured your tailbone or you have something else within your bones. And we have to rule all that out first, right? Make sure you don't have something actual legitimate. Then we figure out that the reason you have pain all the time is because you have this, because your brain's not getting the right message from you there. So hard to figure out. Because sometimes it is, the rest of us perceive it as being, well, gosh, they went, you know, right 15 minutes without whining about your pain. Well, it's actually a legitimate thing, but hard to diagnose for sure. And SSRIs, antidepressants, like I said, to improve that neurotransmission from your brain out. So you're not in pain all the time. In a caution sign, when you have patients that are taking this group of medications, it may cause drowsiness and sleepiness. It may cause drowsiness and sleepiness. So the scenario that we were talking about, when I was talking about with Daniel, what if he tells me he has a 45-minute drive to school every day? And he says, I get up and I take my Cymbalta before I leave so I'm not visible sitting in the classroom. What is our worry about him driving 45 minutes to get here? Yeah, for sure. Tell me what you do on a day-to-day basis. What kind of drive do you have? Do you operate heavy machinery? Do you go out there in the tractor or the combine in the fields right now? Tell me when you take the medications. Tell me what you do on a day-to-day basis. I don't want you falling asleep at the wheel or falling asleep at the combine or whatever you're doing. Why drive a bus? Well, tell me when you're taking your Cymbalta, you driving a bus, a city bus, it's probably not gonna work for you to take Cymbalta at the same time. So caution, definitely do a good assessment to find out if you're gonna put that patient at risk for him falling asleep or her falling asleep, whatever activity he's doing. Again, SSRIs are a good option for this patient, improving their pathway conduction. A lot of you that work on the floors sometimes will administer gabapentin. We use that for patients that have nerve pathway issues. So maybe we can improve that messaging from the brain to the pain receptors. So the patient doesn't have so much pain all the time. So the patient can sit longer and have improved activities of daily living.
So the last, I think, 2 slides ago, it said it causes drowsiness and sleepiness. There's like some SSRIs that like say to take it in the morning.
What's up?
There's like some like SSRIs that tell you to like take it in the morning, but then it says it may cause drowsiness.
I wouldn't take it in the morning if you're expected to be with the programs. You're right. I mean, because I think the thinking is some of those levels are low through the night, and that's why they sometimes, if you're learning mental health, to take those in the morning. But do really do a good assessment for this patient here, because if you're expected to function, you're babysitting kids, you're in clinicals, you're doing other things. We don't want to fall asleep at the wheel. I like muscles relaxing, so a lot of those have that same warning on them. Yeah, good questions. Work with your patient, you know, on that MAR when we're in clinical. So as I said, you can request pharmacy to order a different time to give this medication. We're gonna mess with the patient's med schedule when you get to our hospital, right? Like, oh, we're gonna give you every medication you possibly take at 9 o'clock this morning. Well, I don't take that one at 9, I take that one at noon, I take that one at 5. You as a nurse can always message pharmacy and say, schedule daily med at 5 o'clock tonight. Schedule is diuretic at 4 o'clock instead of 9 o'clock tonight. So work with your patient, only takes a message, because default is once a day is 9 a.m., twice a day is gonna be 9 and 9. That's just the way the system is set up. But you can certainly advocate for your patient. Tell me when you take this at home, because I don't wanna screw up your schedule when you're here, so when you get home, I'm gonna try to keep it about the same as you do at home. So advocate for your patient. Who's got questions about what we just covered since lunch? Anything, anybody? Got a good handle on stuff? Do you want to take a break, or do you want to go and then get out at 10 till 2? Anybody have a? Just go.
Yeah,
Okay.
go. Yeah,
You know,
let's
you
go.
can always take a break. You can always get off and take attendance and all that stuff. So, okay, we're gonna go over some NCLEX questions, and then we'll do a little bit about general stuff for testing.
We have 5 more.
Maybe she'll do 3 or 4.
Yeah. That'd be nice. Are you able to send me
People
that
ask me how people, the rumor is Tuskegee is horrible, right?
Yeah,
That's the rumor, yeah, I know that. It's not horrible, but stuff.
Put some questions up.
Oh, yeah.
Studying the fact that a lot of the respiratory and cardiac things especially are just good groundwork, foundational information to have from now till forever. So that's one reason to know it. And then just don't get into a whole, this point of the semester period. So